Hello, I'm Janice Karen, Director of Policy, Technology, and Innovation at the Massachusetts Health Data Consortium, or MHDC. I run our Data Governance Collaborative, also known as the DGC. We start each of our weekly meetings with a series of industry quick updates to learn about new and proposed regulations, laws, standards, industry initiatives, and other activity. Join us for this week's updates. And if we'll move to the first update, the Government Accountability Office has put out a report on electronic health information exchange. It was released on April 21st. It has some interesting stuff, but it ignores FHIR completely. And they included contact information and a bunch of stuff like that. So I wrote to the person who is overall responsible for the report. I got a very nice, very rapid response. But they told us that FHIR was specifically out of scope. I just pointed out that I thought that was unfortunate because I didn't feel like some of the goals that they stated were their goals for the report could be met without considering FHIR. And moving on to that, the stated goals of the report are to describe states' use of high-tech funding for health information exchange efforts and their plans to replace those funds as those funds are no longer available. I believe they ended at the end of 2021, but I might be wrong about that. But they're definitely gone now. The extent to which the use of electronic health information exchange has changed since high tech. And this last one is where FHIR seems particularly applicable. Federal efforts that aim to address challenges to electronic health information exchange. So the report does talk a bit about TEFCA. So I think that they clearly are looking at upcoming and new stuff, which was again part of the goal for goal number 3. And they talk about TEFCA as a possible solution to some of the issues that they found. And in fact, in the response that I got back from the person who wrote the report, even in that response, when I asked about FHIR, I got back, but we did look at TEFCA. And so there seems to be some real push for TEFCA as sort of the great white hope, if you'll pardon the expression. So I thought that in of itself was a little bit telling to me. If you'll go to the next slide, there's a second slide on this. So the thing that I thought was most interesting about the report was they took a look at the type of access. They split hospitals, this is all hospital access, and they split it into small and not small. And I did not dig in, I did not go down to the point if they explained it to fully understand where they made that distinction. But they talked about basically what they did is they asked each of these organizations, each of these hospitals, do they often send or often receive the following? And you can see that, not shockingly, mail-in fax, which they grouped together, was more prevalent in small hospitals versus not small hospitals, whereas the other hospitals were more likely to be using regional and state and local HIEs than the small hospitals were. They were also more likely to use their EHR vendor networks and basically to use any type of formal network more often than the small hospitals. So not surprising. What I did find interesting was that in almost all cases, the exception being mail, they were all more likely to send than receive. So clearly there's a lot of sending of mail where people, sending stuffy HIEs where they're getting stuff back by mail and fax to the same organizations. So that's the only way to explain the number. So that was kind of interesting. You can find some more information in the full report at that link. I have not, it's fairly long. It is interesting. These are kind of top level things. I have not read the full entire report yet, although I have looked at portions of it, particularly the portions around TEFCA and some of those other components in more detail. Any questions or comments here?
Janice, I'll just make a comment that Nehan actually filled out the survey for this report, just as an FYI.
Oh, interesting.
As an HIE, yeah. I mean, a lot of the questions weren't really relevant to the type of transactions that Nehan does, but it was a fairly long survey. I mean, it took me probably almost an hour to fill it out.
Oh, wow. How long ago did they gather the data? When was that? When was it, if you remember?
Maybe only like a month ago that I got the survey, but I mean, it seemed like they'd been collecting it for a while, but it was pretty quick. Quick turnaround from that to this,
Yeah, it must have been towards the end, because like I said, this report came out April 21st. And they definitely seem to be very on top of things. Like I said, they responded to my email within a few hours. And I got a response from the head, not the person whose name was on the report. From the title, it seemed to be fairly high up organizationally, and she responded personally. She CC'd a couple of other people for additional comment if they wished to give it. And so I was actually, even though I thought it was disappointing that they didn't, that they ignored that entirely, especially with that goal number 3. Overall, I thought that they clearly were making an attempt within the parameters of what they were told to do a really good job of analyzing what was there. And I do plan to read the rest of the report in more detail.
It was an in-depth survey, I'll say that much.
Yep. Cool. Anyone else have any comments or thoughts? All right, moving on to the next item. Let's start the price transparency section of the updates, because there are several. So the first one is that CMS has put out a fact sheet on price transparency enforcement. And unlike most fact sheets, it's not just a fact sheet of what they're doing. It actually highlights some changes that they're making. So this first section does talk about like what the current state of being for price transparency enforcement. So CMS has 3 main avenues for monitoring and assessing compliance. They can evaluate complaints that are made by the public. They can review individual or entities' analysis of non-compliance, or they can do internal audits for hospital websites. And then these 3 avenues lead to cases that are flagged as being non-compliant. And they are prioritized based on the degree to which the hospital appears to be out of compliance with the rules. So for example, a hospital that doesn't have a machine readable price file at all will be prioritized over one that has a file, but it's incomplete. So having said that, the current enforcement process starts with a warning letter. And hospitals are given 90 days to correct the problem in the warning letter. And after 90 days, CMS will send a corrective action plan called the CAP. And they will give, the hospitals have 45 days to submit the CAP. So basically, CMS doesn't say, here's what you're going to do. CMS says, you are now on the hook to give us a plan for getting into compliance. You have 45 days to do that. And then, as I'm not sure if this may happen simultaneously, but they listed it as a separate step. The hospital currently gets to propose a date to CMS as probably as part of the plan for when they will complete the CAP and therefore be in compliance. And it's usually 30 to 90 days. But it's basically, it's not clear how much negotiation is involved in that, or if CMS just says, okay, you think it'll take you 100 days, fine, you have 100 days. And then if at the end of that period of time, the hospital's still not in compliance, then, actually, if the CAP is not completed, you can get a civil monetary penalty. Oh no, that's if it's not, okay, I'm sorry. If the plan is not, if you're still out of compliance, I wrote that a little bit badly, my apologies. I'm getting ahead of myself, which is why I got confused. When we get on to the next page where they talk about the changes, if the cap itself is not supplied, there can be a civil monetary penalty. But under the current system, this penalty is if the cap is not completed in a way that fixes all of the problems, then there can be a civil monetary penalty. So the average time for this entire process is about 195 to 220 days. So that's kind of a wide span for something that's supposed to be an average, but be that as it may, that's what they're saying. So we're talking, you know, more than 6 months for this process. Now, CMS has started making some changes. First of all, they were able to increase, they were doing about 40, they said 30 to 40, but they were at about 40 towards the end of it. Comprehensive reviews a month, they're up to 200. If you go on to the next page, please. And as of April 2023, they had issued 730 of the warning letters, 269 requests for the action plans, and 4 civil monetary penalties. So as you can see, they are getting some level of getting into compliance just from the warning letters. But what they're planning to do is update the enforcement process as follows. So you still start with a warning, except if the hospital is making no apparent attempt to comply with the rules. For instance, if they have no machine readable file, if they don't have a price comparison tool, or if they just seem to be egregiously off, CMS will skip the warning entirely. So the process for those hospitals will start with a request to submit a cap. But for other hospitals, there'll be a warning, and then if things are not brought into compliance, then there'll be a request for a cap. Hospitals will still have 45 days to submit their cap. But instead of suggesting an amount of time, there's a set 90 days, and that 90 days includes the time that the hospital has to do the cap. So at 2 clocks start at once here. The clock to submit your cap and the clock to complete your cap start at the same time. So 90 days later, if you're not in compliance, then you'll get a civil monetary penalty. So that's the plan for the changes. They're basically streamlining the process a bit, trying to make it go a little bit faster and also make it simpler. So they have the sheet outlining all of that at the link. Any questions or comments?
Yeah, Janice, do we know what percentage of hospitals are in compliance versus those that are getting warning letters, requests for caps, or monetary penalties? Like 730 plus 269 plus 4, that's a lot of hospitals, but how
Yeah,
many
actually, that's
passing,
a good question.
you know? Yeah.
Well, you know, they said they had been doing about 40 reviews a month.
Yeah.
And this process had been going for about 2 years.
Okay.
So that's a pretty significant, you know, even if you,
Yeah.
you know, and it was at 30 earlier on. So let's say that, you know, we say there's 400 a year that they're looking at. That's a high percentage of the hospitals that they're getting an actual warning letter that are going through this deep review. So
Right.
I don't know an exact number.
You add these numbers up and you'd start to think, well, is that all of them, maybe?
Well, no, they don't get added because it's a process, right?
No,
So
I see.
the 269
Right,
is a percentage of the 730.
right. Gotcha.
So it's not additive. So it's 730 total that have,
Yep.
Although, you know, there may be some that are in the warning letter stage that may still get caps. So it's not like 269 of the 730. I'm sorry, I'm going to shut up. My inner math geek is coming out.
Got it.
But yeah, I mean, I would say that it's a pretty high percentage of the hospitals, and CMS has been pretty clear that they've had a lot of hospitals that have not been complying. Like they've put out additional guidance about what constitutes compliance. They've put out guidance that specifically says X, Y, and Z does not constitute compliance because a lot of hospitals are trying to do certain things that they don't feel are sufficient. So it's pretty clear that there is not a very high level of full compliance. Now, they're also not getting too far down the civil monetary. They're probably not going for full civil monetary penalties for any but the largest, most egregious violations, because 4 is pretty low given the number of hospitals that have been, clearly not fully compliant on their own. I don't know that 100%. I don't know that all of the rest are fully compliant, or if there's some level of good enough happening.
Gotcha. Thanks.
So, any other questions or thoughts there? Good question, though. All right, then let's move on to the no surprises portion of the price transparency updates. So there are actually 2 different components here. CMS put out 2 separate documents that are kind of related. They put out a process update for the IDR. And update here doesn't mean a change. I thought it actually meant a change, but it's actually some high level. It's like a high level overview of where the process is at for the first year. As you can see, there have been a lot of disputes. So the process opened up on April 15th, 2022. This data goes through March 31st, 2023. And they had 14 times more disputes than they were anticipating. And you can see in about more than a third of the disputes, the non-initiating party challenged the eligibility of the dispute, i.e. whether the disputing party had the right to dispute. Of those, about a third of the challenges were found to actually be ineligible. So 2/3 of the time when they were disputing the eligibility, they were wrong. Of the disputes, payment determinations were rendered in 42,000 about cases, and the initiating party won, as you can see, 71% of the time. So clearly there is a case to be made for going through this process. That's a reasonable winning percentage to say that this is clearly we're right to dispute these things. Now, however, only about a third, less than a third of the disputes have been closed. So there's still over, of the 334,000, almost 335,000, about 228,000 of them are still open. Now, they've closed more than 4 times the amount that they expected to be able to close in that time frame. But going 4 times faster than they anticipated doesn't work when you have 14 times more cases to get through than you were anticipating. So the closure cases, you can see that of the cases that were closed, only about 40% were from payment determination. There's also just about 40% that were ineligible. And then the other 20% might have been closed for a variety of other reasons. Agreement, failure to pay the required fees, problems with the actual application, things like that. There is, as you can see, a large delay on in the resolution. Eligibility determination is the primary reason for dispute processing delays. We'll get on the second set of IDR updates. We're going to talk about that in some more detail, but this process of there can be a lot of complexity around deciding whether or not a dispute is eligible for this dispute resolution process. There are, we'll talk about a lot of them on the next slide. So for now, you can find the update that we're talking about here. So this is just sort of a high level update. I think I have most of the actual data they gave I got in this slide. But it's kind of an interesting look at just how much this process is getting used. Those are pretty high numbers Granted, that's nationally, and there are probably millions and millions and millions of possible disputes, but still, that's a lot. Any comments or thoughts? All right, then let's take a deeper look. So the other thing that they did is they have what they call a partial report on the IDR process just for Q4 2022. This is similar, but a much more detailed look than the annual update that we looked at in the previous slide. However, you can see that there were 110,000 disputes just in Q4 2022. That's just under a third of the total disputes in the full year. And you can see that it was 72,000 in Q3. So they're definitely increasing. The majority of these were for what they're calling out-of-network items or services, non-ambulance service, basically non-air ambulance. 40% of those disputes had their eligibility challenged. So there were, you can see there were 110,000 cases opened. Just under 32,000 disputes were closed. Now, some of those were almost certainly disputes that were opened before Q4. But again, here, we're still at the point where a little bit more than a third of them, 40%, a little bit less than 40% were closed with payment determination. Here, about a third were found ineligible, and then a third were closed for other reasons. Obviously, those numbers are slightly 40, a third doesn't quite add up, but you get the idea. So here's the thing. A lot of the eligibility issues come up. When you look at the IDR process, if states that have all payer models or that have state laws around price transparency that set some of the pricing rules, those states, those things are ineligible for the IDR process. But there are some states that do that for only some of the items and services that are covered. So this is where it gets complex and where a lot of the complexity in determining eligibility comes from. So 2/3 of the disputes that were submitted in Q4 had items and services from states where some of the items and services in the state are eligible for IDR process and some of them aren't. And so sorting through that eligibility is really complex. The three biggest of those states are also the three biggest contributors generally to this process. You can see that just under 25% of the total number of disputes came from Texas. Florida still had about 12%, and Georgia was at like 9%. So those are the three biggest states. All three of them are in this mixed eligibility status. And so every single one of those disputes had to be determined whether or not eligibility happens. And if we go on to the next slide, I don't think, actually, I may not want to mention it, but one of the things that CMS points out in both of these documents is that even if the non-initiating party doesn't dispute the eligibility, the IDR is required to still determine that the dispute is eligible. So every single claim that gets put in, whether or not it's disputed, gets an evaluation for eligibility. Sorry, I forgot I didn't have that down. So looking at the states, as I mentioned, Texas, Florida, and Georgia were the top three. Tennessee and Arizona round out the top five. And between those 5 states, that's 60% of the total disputes. The states with the least number of disputes were New Hampshire, North Dakota, Hawaii, Maine, and Vermont. It is probably not coincidental that those are states that do not have large populations. 2 of them are also in this mixed RDR state. Massachusetts was 29th with 366 disputes. So to me, I was looking at states that were, I took a look, they listed every state. I took a look at some of the states that are somewhat similar in size to Massachusetts, and we had fewer disputes that is a very, very rough analysis. But it seemed like we were on the low end for our size. They also look at they point out the top 10 complaining, the top 10 providers initiating disputes, and then the top 10 payers that get disputes. None of the top 10 providers seemed to have any local presence as far as I could tell, so I just skipped that part. But the two most challenged parties were United Healthcare and Aetna, but each blue was listed separately. 4 of them plus Anthem were in the top 10. Anthem, I'm always a little bit iffy on the exact relationship with Blue Cross, because at times I know they've been connected and some of them seem to be, sometimes it seems independent, so I'm not positive, but I put it down there. But I would be certain that if you put all the blues together, they would be by far the biggest, most challenged party. Like I said, 4 or 5 of the top 10 were blues. So they also, the other thing they did, which was kind of interesting, was they looked at the settings that were most frequently getting disputed. And you'll notice these numbers add up to more than 100%. That's because some disputes involve more than one location. But so the emergency room at a hospital is by far the area where the largest number of disputes happen, and followed by inpatient hospitals, and then on-campus outpatient hospitals. It's not clear to me why on-campus outpatient hospitals should be significantly higher than off-campus outpatient hospitals, but they are. Those top 3 you can see are basically the vast majority of the disputes. There's some ambulatory surgical center. There were like 300 in total on the independent laboratory. And off-campus outpatient hospitals were lower than I would have expected. And like I said, I don't understand why there's such a difference between on-campus and off-campus. But anyone have any comments on any of that? You can find the full report at the link.
Hey, Janice, this is Melissa. I don't know if you know
Hey,
this
Melissa.
off the top of your head. Do you know how that compares to the mix of claims? Like how many of those claims are actually emergency room at hospital claims? Like, is it a huge, I'm just curious how much of a disparity there is between claims mix versus dispute mix.
You know, that's a really good question. I don't know that. Denny, or does anyone else know that by any chance?
I don't, Janice, but I was going to ask a similar
No,
question.
I don't either.
Yeah, I don't either, but I was going to ask a similar question of it. Do they publish the type of dispute? Is it like, are they saying, payment dispute for underpayment or overpayment, or any, data about the types of disputes that are going on?
Well, the vast majority of disputes, so when I said they published the providers that were initiating the disputes and the payers who were getting disputed, they didn't list it as these are the providers. They said these are the entities. So the providers seem to be almost overwhelmingly the ones who are initiating the disputes. So that would lean towards mostly underpayments.
Yeah, I would guess.
And obviously, and all of the top 10 people being disputed were definitely payers. So they did not break things down further than like all medical items and services were grouped together. They did not break that down further into the types of services.
Right. Interesting.
It does say partial report, so I wonder if there will be a full report later that actually does do more breakdown of data. And that's why this is considered a partial report. But I don't know that for certain.
Interesting.
I will see if I can, I've made a note. I will see if I can come up with a normal, like average mix of claim locations and see if we can do that comparison later, because that is a really interesting question. Anyone else?
Well, I think your observation that
the Blues were in the top 10 is to be expected, since they tend to be the one of the larger carriers in any given market. And United and Aetna obviously are two of the largest nationals.
Yep.
And the relationship between Anthem and Blues is that Anthem owns and operates some Blue Cross plans across the country. So it's Anthem Blue Cross of Maine, for example.
Gotcha. Yeah, I know at one point Anthem was Blue Cross of California, and then something weird happened. But that was my first introduction to Anthem. Was I was working for a company that was based in California, and I was given Anthem insurance. I'm like, oh, I've never heard of them. They're like, yes, you have. It's Blue Cross.
Right.
So that was my introduction to Anthem. But in any case, yeah, I don't think any of that was very surprising. And I do think, I mean, and the states that the specific Blues that were listed were those states that had, were Florida, Tennessee, the ones that are in those top states. So that wasn't shocking in any way. Like I said, I found it more interesting. The thing that I found more interesting was that on-campus versus off-campus outpatient hospital difference. That was the one thing that struck out at me as being really weird in the bits of data that they provided. But all right, anyone else before we move on? All right, let's go on then. So CMS has put out a FAQ on the end of the public health emergency. It is mostly focused on how testing and vaccines and COVID treatments will be treated moving forward, but it does discuss some of the other components. And it covers the span of different types of plans, including a few comments that are general and not specific to CMS plans. But then there's also sections that are specific to Medicaid and CHIP and stuff like that. So the main thrust is that most of the testing coverage, most of the over-the-counter testing, and a lot of the anything that can be considered over-the-counter will no longer be covered as of May 11th. For Medicaid and CHIP, I believe it's extended to September 30th for some of those things. But there were a few interesting things that they talked about. For instance, there were a few cases where in order to be eligible for certain things, you had to do a 6-month monitoring on site. And so there were they addressed the question of whether, as soon as the public health emergency goes away, if you haven't had an insight in the last 6 months because you weren't required to, the day before, are you out of compliance immediately? And CMS basically said no. Those types of things will start getting checked 6 months after the end of the public health emergency. So basically, the timer on getting the on-site care, if in one of these types of situations, starts the day after the public health emergency ends. And so if it's a 6-month requirement, you have 6 months from then. And then at the end of the 6 months, they'll start enforcing that again. If it's a 3-month requirement, similarly, at the 3 months after the end of the public health emergency, that'll start being a requirement again. So you can find the full FAQ there. And it does, it is like unlike some of the other stuff we've posted, this is definitely more specifically CMS focused, and also a little bit more focused on actually dealing with COVID after the end of the public health emergency, although not entirely focused on that. Any thoughts or questions there? All right, I believe that is the last update. If you'll go on to the next slide and pause there. I hope you learned a lot from our quick updates. If you're interested in finding out more about the DGC and its other activities, email me at dgc@mahealthdata.org. That email address is also on your screen.